So raise your hand if you belong to an American family. Seriously, raise your hand if you're in an American family. Raise your hand, all the hands up. So on average, keep the hands up because there's a punchline coming. Each and every one of you, every year, spends $4,200 on care that does not make you better. Wait, keep the hands up, there's a punchline coming. So $4,200, that may not be a lot of money, depending upon your socio-demographic. If you're here in DC or attending something like this, it's about 10% of the average American household's disposable income. I live in Kentucky, and in rural Kentucky, I'll tell you, $4,200 is an amazing amount of money. It's literally money that comes out of food, clothing, shelter, and education. The punchline is, though, of course if you're sick, but if you're poor and you're at risk and you don't have access to care, you don't waste less, you actually waste more. That's the punchline, and that's something that we've all created for the past 30 years by perversely incentivizing the market. You can put your hands down. That is the talk today. 50 Shades of Variation, how we've perversely incentivized the market for decades. What is high and low value care and how is that helping? And then we're going to tell you a story of what's actually going on in the marketplace. Not through collaborations, not in academic circles, but literally in the marketplace. It turns out a third of the American population is being managed by this right now. It's not startup aspirational sentiment. This is happening right now under your nose, and that's going to be the story today. So our friends at the Institute of Medicine, I hope the slide it's self-explanatory, right? Everybody gets this? So they basically say a third of every dollar goes to nothing. And if you get them behind closed doors, they'll tell you this is a conservative estimate. A third of every dollar goes to waste, abuse, and low-value care. It's about $1 trillion a year. It's 10% of your average state's GDP. It's a lot of money out of your household. That goes to waste and abuse, which is relatively easy to understand. Low-value care is a little bit different. Low-value care, in essence, is, sometimes I have these choices, right? I can choose treatment. The classic example of this, and if you've been in DC for more than 10 minutes, you've no doubt listened to NPR. And on NPR, each and every time you turn it on, they will be talking about low back pain. And low back pain is the classic example. And so I don't have acute thrombosis, I haven't been in a car accident, I'm kind of fat, probably not going to lose the weight. I can do physical therapy. I can get a decompression where they tap on my back with a little hammer, ticka, 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 ticka. Or I can get a spinal fusion where they jam a big needle into my vertebrae, shoot concrete, and glue it together. The outcomes are all the same. The experience, the downtime, and productivity, and family, and the pain are not the same. The outcomes are the same. The cost is not the same. One costs $8,000, one costs $18,000, one costs $80,000. So why would we choose the $80,000 treatment when the $8,000 treatment works just as well? And the answer, quite obviously, is because some people make $80,000 off of that treatment. And so these definitions are not new, and this research is not new. We have Winberg and the Dartmouth folks on our board, and that's great. I'm going to summarize their research, and the Winbergs hate it when I do this in a minute. But here's 30 years of academic research in 1 minute. Every provider has a unique fingerprint. Every doctor is a snowflake. And yes, they operate within guidelines of care, but so too do they operate and choose treatment based on things like training, preference, and supply. Supply is really interesting. Supply is gambling, pornography, prostitution, and healthcare. All supply-driven. Not demand-driven, supply-driven. What does that look like in healthcare? Oh, that's hyperbole. If I have a new wing full of hospital beds, I'm probably going to fill them. If I just purchased a new MRI machine and it's shiny, I'm probably going to use it. And if I have 5 times as many orthopedic surgeons and an HRR and a geography, probably going to be doing a lot of those $80,000 fusions. This slide, likewise, is self-explanatory. Let's go on to the next one. But essentially, I'm looking at a variety of subspecialists that have case-mix-adjusted populations. I'm looking at 2 people. The woman in the middle, as I go down the index of care, she's doing a lot of utilization. She's doing a lot of those decompressions, she's doing a lot of MRIs, and she has a high unit cost. She's using spendy MRIs, but nobody is funneling down to the operating table. The guy next door, he has lower utilization, he has a lower unit cost, he's using Joe's discount MRIs. The thing is, if you walk into his office on Monday, he is booking you and you will be in that red circle down there on his operating table on Tuesday. That's why he's not using the MRIs. He already knows what he's going to do. The funny thing is, the actuaries tend to like him. Low unit cost, low utilization. She's doing appropriate care, but the payers historically have not incentivized her. She's not doing those $80,000 treatments, so she has cash flow problems and she's financially upside down. Funny story, huh? The interesting thing is these definitions are not newly available. They've been out for decades. We know what they are. Dartmouth, other folks like Choosing Wisely and ACP have hopped on in recent days, and they cover every specialty, including PCP. What's particularly interesting about that, click, is that red dot, green dot, those two have the same outcomes. She and he have the same outcomes. She has a green circle because she's doing high-value care. It takes her less dollars to get to those outcomes. He is low-value care. It takes him more dollars to get to those outcomes. So when we at RowdMap profile every provider in the United States, every facility, post-acute center, individual MPI, and group, we do red dots and green dots, but they tend to mean different things to quality people, which we learned. Red dot does not mean you're bad. You can be awesome. You're just doing a lot of stuff you shouldn't be doing. Green dot doesn't mean you're great. It means you have the same quality, but you're doing it at less dollars. And oftentimes those correlate, but sometimes they don't. If you're in an academic med center, if you're that guy who's doing those fusions all day long, each and every day, you tend to get really good at it. And if you're doing it on everybody, even the people that don't need it, you tend to do it on younger and healthier people and get even better outcomes. Ha-ha. I guess. Ha-ha. Okay, so we need to think about red and green a little bit differently. And to use this analogy, I find this helps sometimes. How many people have seen the movie Moneyball? Read the book? They're always very different parts of the audience, who's read the book and who's seen the movie. But Billy Bean, or Brad Pitt, depending upon where you're coming from, is very sad at the end of the movie. He's so sad. The Yankees beat him again. And Henry, the Sox owner, is saying, hey, buddy, it's okay. Funny thing is, you had the same number of wins, the exact same number of wins as the Yankees. They spent $2.4 million per win. You spent $540K per win. Same number of wins, different number of dollars to get there. The model that revolutionized that game was dollar per win. That's what we're doing, dollar per outcome. How many dollars does it take you to get to those outcomes is the real question, wrapped with appropriateness, which is kind of stunning when you think about what that might mean for Triple Aim. Presenting the official new Triple Aim logo. I don't know if this is past marketing yet. Maybe the stethoscope, probably not the sack of cash, definitely not the Jack in the Box. But the point of the story is you can have a great clinical outcome on a surgery you don't need. You can have a low cost on, anybody? A surgery you don't need. And wait for it, you can have a great patient experience on a surgery you don't need. Awesome Triple Aim on stuff you don't need. The problem was appropriateness was difficult to wrap. Since then, folks like the HCTTF, all the major payers, all the major provider groups have come together and said, if we're going to pay docs, we need to pay them not just on their A1C, HEDIS is great, of course, but also on whether they're doing a lot of those $80,000 fusions or high-value care. And that's come up into white papers for CMS and VA and TRICARE, as well as in the private market, which is pretty interesting that they've come along and done that. Of course, the difficulty is to get the data to be able to do that. Fortunately, CMS released 3 years of longitude, perfectly price adjusted with no pricing noise in it, for every provider in the United States, 97% of the MPIs. That's pretty cool to build a model on. You didn't have to beg, borrow, and steal to get a little bit and do a little research. You could start with this, which was awesome. The links up there are your guides to use it, and I even put together a guide how to go about building it yourself, which will be available after this. When you use that data with other data, there's Winberg up there, you can do fantastic things. How many people have heard of Berthas, behavioral risks? No? Okay. Berthas is a great data set, but it's an old school data set. It's a 1970s data set. It's a mustache-wearing, jean jacket-wearing, El Camino driving data set from the CDC. It is not artificial intelligence. It is not precision medicine. It is not even clinical data. It's not even claims. It's telephone survey data. And of course, we all know that telephone surveys don't predict anything, right? Haha, I'll wait for it. You can think about that later. The point is, they actually do predict quite a few things. That's why we publish this in the BMJ. It turns out using that data actually outpredicts risk models, private and CMS HCCs, as well as actual disease burden. The poorest and most at-risk people, social determinants, are underrepresented in the system in such a way that they don't get appropriate dollars from private payers or from CMS. Funny story. And as a repentant academic, PhD, Fulbright Sorbonne Institute for Advanced Study, I will tell you, as a repentant academic, our smarts are massively limited. The poorest and sickest are underrepresented. And even when we adjust it, pick your model, Charleston or this or that, they're still underrepresented. So that's why we started saying, hey, if you're poor and at risk, you spend more than $4,200, ha-ha, here's one way to think about it. Not so much of a ha-ha. We tie these dots to dollars, a lot of dollars. I'll save it for another time. At RowdMap, we actually have every provider in the United States, red, green, et cetera, which is pretty cool. Subspecialty adjusted, based on their practice pattern, geographically adjusted, so you can take into account supply. Pretty cool. What drives the low-value care, whether you're a red dot or a green dot, might be your procedures, your visits, your prescription patterns, or even your referrals, because the data actually lets you see where patients are flowing. You may be a train wreck of a PCP, but you're sending half your people to a superstar and half your people to likewise a train wreck. And so that's important because you're only 4% of the spend. And so you look at it, you figure out what's going on. It's pretty interesting. Of course, behind that, you have to have deep clinical ontology and some other stuff. I don't want to dwell on any of this stuff. I want to dwell on what's going on in the market. We started this as 5 guys and gals in a barn. Last year, we were literally in Kentucky in a barn. Last year, we were in 10 states managing 10 million members and patients. At the end of last year, we were in 50 states managing 100 million members and patients, government programs, national payers, regional payers, provider-owned payers, large group, small group, Medicare, Medicaid, other government programs, and providers. High-flying providers like Hopkins and Geisinger, little middle-of-the-road American providers that are just trying to eke by. And the really interesting thing about that is when you know who's high value and low value, you change the conversation. It's not about who has good clinical outcomes or poor clinical outcomes. It's about who are the Oakland A's and who are the New York Yankees. Same outcomes, but practicing differently. And payers and providers tend to use that very differently. Active case studies for a third of the American population include creating networks, tiering networks, steering members to high value through operational means, which may be invisible to members, taking care of them behind the scenes, as well as paying them. They go to this little institute where they share their own best practices. Literally, they say, who's high value, who's low value? High value doesn't mean better clinical outcomes. It means creating value and profit for the risk owner, which is really interesting in terms of payment. The biggest surprise we had was that we didn't need to do it through value-based models. We thought we did, because value-based models are awesome. If you want to do affordable care, you get rid of the 30 cents out of every dollar. Value-based models curb that behavior. It's great. The problem is they're hyper difficult for payers to implement. They're even more difficult for providers to implement. I'm going to take my cash flow, wait till the end of the quarter, then the year, keep an Excel sheet, have to do an MSSP, an ACO. It's difficult. If you literally pay the green dots more and the red dots less through the existing fee-for-service infrastructure, which is why we joined the Cotivity family to have pipes into every payer in the country, it makes it really, really easy, and you cash flow them, and it's great. The surprising thing was we learned you can even do that through a universal payment model. What I mean by that is in states where you can't mess with anyone's contracts, you literally go to the payers, every single one of them, and you say, we're going to pay you more. No strings attached. If you do those decompressions, we're going to pay you 20% more. First of all, providers tend to take those meetings. Second of all, despite their squeals and protests that they're operating with evidence-based guidelines, they somehow field adjust and they stop doing those fusions, which is really fascinating. You knock on the door saying, I'm going to pay you 20% more for the decompression. Magically, they stop doing the fusions. You're literally using money to accomplish the right thing. Which takes us to this. I used to give this lecture for years and years and years at Harvard. It was something innovation or healthcare or something. But the point of this is your 1-minute Harvard MBA, healthcare concentration. And I think this slide sums it up. So on the left, as you can see, it's very easy to make money in healthcare, to be profitable. The problem is if it's easy, you're probably doing questionable things. Likewise, you can do public and social good, but it's very difficult to be profitable doing that. And you're always going hat in hand, and it's a debacle. The trick is, can you do both? Can you create market value while delivering public and social good? And affordable care is that middle ground. The Harvard kids would always roll their eyes because it's not Silicon Valley, and it's not New York, and it's not genomics, and it's not precisionalized medicine, or any of this other stuff we heard. It's literally aligning dollars around fee-for-service models to pay people more to do the right thing, to undo what we've done for 30 years of incentivizing people to do the wrong thing, to pay the woman who's doing a lot of utilization at a high unit cost more so she can cash flow, and literally to put not only $1 trillion back every year nationally, put 10% of your GDP back in your communities, $4,200 back in your pockets, even more money back in the pockets of those who need it the most for food, clothing, shelter, education. And that's a pretty fantastic thing that is being accomplished today, somewhat unbeknownst to people. So no shades of gray in that. Thank you very much for your time and attention.